Hi, I'm Wendy Lang. I'm from Oak Hills Living Center, and we are here today to talk about the role of long-term care in the patient care continuum. And thank you today for joining us. We have Dr. Joan Kriekera and Dr. Mario de Souza. So tell us a little bit about yourselves and your role with Oak Hills.
I'll go first. I'm Joan Kriekera. I'm an internist. And in the 30 years I've been here in New Ulm, I was the medical director of Oak Hills Living Center, both the assisted living and the nursing home side for the 30 years I was in practice. I've taken care of many residents of the nursing home in the clinic, in the nursing home, and in the hospital over the 30 years, and have worked with the staff in terms of quality of care issues and policies and procedures and patient safety and all kinds of things in the nursing home.
Excellent.
My name is Mario de Souza. I'm an orthopedic surgeon, and I practiced in New Ulm for 31 years. I just retired in September of 2021. And I have been associated with Oak Hills in terms of, first of all, sending them a lot of my patients for care afterwards, and secondly, receiving patients from there that needed help. I haven't spent a lot of time at the facility itself, other than to tour it recently and really be amazed by how bright it is, how modern it is, how comfortable it is, and how great the food is, actually.
Yes, we have a great catering department and a great dietary department, and we're very grateful for that. Well, tell me a little bit about, in your experience, what medical services are provided to help our long-term residents stay healthy.
On the nursing home side, we have nurse practitioners and physicians who round in the facility on a regular basis. Our nurse practitioners are there, I believe, it's about once a week. Our physicians are there once a month or a little bit more often, depending. Our podiatrist makes regular visits there as well. And of course, residents of the nursing home come over to the clinic for other services. I know that they can get their blood drawn at the nursing home, so that's kind of nice because sometimes people need blood work but don't actually need to see a provider. Mm-hmm. But if they need an x-ray test or an IV medication or other special testing, they come over to the clinic for those things.
Great. And at the nursing home, we also have a physical therapy department where we provide physical therapy, occupational therapy, speech therapy, as well as mentioning the food. We have a registered dietitian that handles all of our nutrition needs as well. So what happens when long-term care residents' health needs change? Do you ever order, or did you ever order physical therapy for a long-term care resident?
Actually, quite often. People that are in long-term care they age just like people who are living in their own home age. And so as they age, their needs change. If you think about yourself and you're going from age 20 to 30 to 70 to 80, your needs are going to change. And that's true of people living in long-term care as well. And so when somebody has a change in their status, whether they're living in assisted living and want to stay in assisted living, or whether they're requiring enough care to live in a nursing home, when their needs change, that gets addressed by evaluation to determine kind of why did it change, and then intervention to help to make the change or keep the person as functional as they can. It's not possible to stop the change of aging. That does not happen. But it is definitely possible to help people age with a high level of function.
Excellent. Dr. de Souza, will you tell us a little bit about your experience in referring your patients for rehab after a joint replacement or other needs, and their response to that treatment and their outcomes?
Well, I would say pretty close to 100% of my patients required some sort of physical therapy. Some of them only needed it for a few weeks until they could be independent, but a lot of them needed it for a lot longer than that. And the advantage of having physical therapy nearby is that you could monitor how the patients were doing, and they kept constant communication with me if something changed, if they needed more help. Or if there was someone that was already a resident of Oak Hills that, say, broke their humerus by their shoulder, then I could put them on a graduated program, knowing that the physical therapist would follow it until they met certain goals and then keep going. In order to get my patients into the short-term rehab, I believe they had to have physical therapy, or at least from the orthopedic patients they did. And then I used occupational therapy if someone had an upper extremity injury, hand, elbow, shoulder, whatever, which is what we normally think of as occupational therapy. But in addition, if I had a patient that might be a candidate to go home or go to a lower level of care, then I'd have the occupational therapy department see them, assess them, decide what they needed, and then treat that part of them so that they would then be able to go home or wherever.
So were any of your patients ever resistant to a short-term rehab stay?
Oh, sure. I think probably half of my patients or more felt they could just go right home until we could show them that they really couldn't. I think there was a stigma against nursing homes, which is really dropping now. That it was a place you went to for months to years, and it was sort of dreary and boring. And I really enjoyed when people would come back for the 2-week check and say, "Boy, that was great. I never knew a nursing home was anything like that." And I'd say, well, at different sections of the nursing home, but even still. In fact, I had a few patients over the years that were kind of on the border as to whether they should be living at home at all anyway. And after they had an injury or a surgery and went to Oak Hills, decided that they were going to stay there and transferred into some of the more long-term care.
Excellent. Do you have any experience with those same scenarios? Any patients that you referred to a short-term stay versus the patients that you managed in the long term?
Absolutely. People that are in the hospital for medical illnesses, like congestive heart failure, pneumonia, those kinds of things, sometimes are so weakened by their condition of illness that when it comes time to return to their own home or their assisted living apartment, they're just too weak to do that. It's a little bit different kind of rehab because it's really global rehab. Or stroke patients would be another example. People in that situation often get more than one kind of rehab. Stroke patients often get speech therapy, occupational therapy, and physical therapy. People who are weak because of illness typically get occupational therapy and also physical therapy. And the goal is for each individual is to get them back to independent living or to the lifestyle that they had before. That goal is not always achieved, but it's really quite remarkable how much improvement people make when they get therapy. Their improvement is quite quick usually. The average length of time in a nursing home for a medically ill patient is probably 2 to 3 weeks. Some people take longer, especially stroke patients, if it's a pretty significant stroke. But people get strong and are back to their apartments or their homes faster than you might expect.
Yeah, the goal in short-term rehab really is to get patients and people from the community back to the lives that they enjoy. Like Dr. D'Souza said, some stay with us, but our goal is to get people back to the lives that they've lived.
And a lot of my patients that went home, if they needed therapy, would come back to Oak Hills for outpatient therapy because they already knew the therapy department. They felt comfortable there. And I always gave them the choice of going wherever they wanted. And a significant portion decided to come back to Oak Hills for outpatient therapy.
Yeah, absolutely. And that is doable for sure. Dr. Kriekera, can you tell me the difference between the assisted living side and the long-term care facility in terms of medical management?
Sure. People that are living in the nursing home side require more assistance of all kinds. More nursing care, more help with what we call activities of daily living, which is more help with dressing, sometimes help with eating, those kinds of things. Those individuals tend to have more medical services brought to them because it's harder for them to get to the clinic. They will tend to have their blood drawn there. They'll tend to get visited by nurse practitioners or doctors in their room. People in assisted living, on the other hand, are getting some services. They usually are getting their meals prepared for them, and they maybe get some housekeeping services, but they're responsible for managing their dressing, and some of them are taking their own pills and all kinds of things. They do lots of things on their own. That population tends to prefer to have outings and go places, just like the rest of us. I like to have outings too. And they will tend to come to the clinic for their doctor appointments and come to the clinic for their lab work and that kind of stuff. So it's a little different population. People that live in assisted living have already lost some of their independence, obviously, because they came from somewhere else where they were cooking their own meals and washing their own clothes and running their own vacuum cleaner. But at some point in time when they could no longer do some of those things, assisted living is a great option for them. But they still want as much independence as they can. I guess to me, that's the big message for all of us, is that no matter who you are, whether you're young or old, you value your independence. And so when you are no longer able to be 100% independent, like driving your own car, running your own washing machine, cooking your own food, having a situation where you can have as much independence as you can tolerate and safely do is in your best interest. And facilities like Oak Hills help people figure out what they can do and help them maintain that as long as possible.
Excellent.
I like the safely do, because a lot of people who are used to being independent are very strong-minded about that, and they don't realize how unsafe they are sometimes. And the last thing we want is for someone to go home, fall down, and break their other hip. And I've seen that happen more than once.
So in terms of your medical experience, how significant is long-term care and short-term care and assisted living in the whole medical continuum?
Well, from my perspective, it's really a necessary part of a community health system, because everybody, not everybody, but vast majority of people at some point in time in their life are going to need some help greater than what they can get through their families. Some people have families that can drop everything and not go to work and give them 24-hour care, but most people don't have that. Most people's families are still working or maybe are not physically capable of helping them. And so having something available where you have a safe place to live, where you can get the help you need. My own personal experience is my dad, who was born on the farm that he lived on all his life. When my mother died, he could not cook. He had never learned to cook, he couldn't cook, and he loved to eat. Secondly, we didn't want him to drive. He wanted to drive. We thought it was a bad plan. And in the end, he spent the last 3 years of his life in assisted living. And it was a super good experience for him. He didn't have to drive, which made us happy and him safer. And they had great food.
Yeah.
And he loved to eat. So it was a win. Even in spite of COVID, he was living in assisted living in the middle of COVID. And, he said he would have been more isolated living alone on a farm than he was in assisted living. So, and I think many families have those kinds of experiences. My dad never did live in a nursing home. He was able to live in assisted living until he died. But it's a great example of how you look at the person and you say, how can I keep this person happy, healthy, safe, and independent as possible? And yet, he wasn't as independent as he was, but he quickly appreciated the fact that somebody was making him 3 meals a day. And because we were trying to do that with frozen food, and it did not work. It was a bad plan.
No, it certainly is not the same as having a home-cooked, balanced diet, freshly made from skilled people in the kitchen.
I think I'll add to that when I'd see elderly patients with injuries that we'd admit, in general, the people from facilities, assisted living, nursing home, tended to have better nutrition. I'm not saying people at home didn't eat well, but overall for balanced meals for health, if someone came in with a broken hip, for instance, and they had good nutrition, they had good protein counts, they had good lymphocyte counts, they had many fewer complications, particularly infections. And so for me, when I got a patient from a facility, a nursing home assisted living facility, I could be more confident knowing that they'd more likely do well with the surgery and the rehab. I'm not saying people from home didn't eat well, many of them did, but overall I'd say the nutritional health was better in people that came from places like Oak Hills.
So do either of you have any personal stories that stand out in all the years that you've cared for patients? Remarkable stories of success or just unique stories that stand out in your mind?
Well, I can speak probably best to the changes that have happened in nursing homes in the past 30 years. Nursing homes 30 years ago were much more institutional, and they had much more rigorous rules that the patient had to sort of fit into the schedule and fit into the rules. And that has really all changed. Now I happen to be married to somebody who likes to sleep till 10 o'clock in the morning. I happen to like to get up at 6 o'clock in the morning, so we just live a different schedule. That's normal for us. But in the meanwhile, if you happen to be that person who sleeps till 10 o'clock in the morning and you now have to live in a nursing home because you've had a stroke or whatever, that really doesn't change your desire to sleep till 10 o'clock in the morning. That's really kind of part of you. And the current nursing homes really allow people to really have their own schedule. If you're not an up for breakfast person, they let you sleep and you get up when you want to get up. That really is a huge change, and I think has really made it better for people. In terms of the happiness factor of, it's hard to move out of your home. That's tough on anybody. And to move out of your home, but have people realize that you have your own individual interests, whether it be the books you like to read or the TV you like to watch or the fact that you want to sleep till 10 o'clock in the morning or whatever it is, it really is a good thing that people are allowed to do that. That's kind of an observation I've made about all patients, about how much happier they are and how much more it works for people now. And it's nice to see that, because it was a wrong opinion or a wrong plan to say we're going to put everybody in the same bucket and it's going to work out for them, because that doesn't work, and it wouldn't work for the three of us either.
No,
Probably.
I'm sure not.
I can think of a couple of stories. As I said before, I did not go to Oak Hills very frequently. But I remember one time I had a patient who had a special dressing I had on, and I got a call in the afternoon that the dressing had fallen off. And I thought, oh dear, what do I do? So I said, just leave it alone. When I was done with the clinic at 5 o'clock, I came down with my dressings and I changed the dressing the way I wanted it. And I heard the other people say, wow, you must be really special. Your doctor came here to do that for you. And then another time it was about noon, and there was a lady at the front of the clinic in a wheelchair, and she was fretting that her ride hadn't come to pick her up yet, and I didn't know who she was. I said, where are you going? She said, Oak Hills, I'm going to miss dinner. I said, let's go then. So I grabbed the wheelchair, and we walked all the way down here, and I was thinking, I hope she is right. And we got through the front door, and the attendant said, hi, Mildred, or whatever her name was, and I thought, oh, thank God.
Got to the right place.
So I couldn't have done that any other place, I guess.
That's so awesome. That's just the beauty of a small town and such a close-knit community, and having all of our medical care just so close together.
Yeah,
It really is a blessing in this New Ulm community.
We've also had staff that worked at both places, and they'd keep an eye for me, and they'd say, oh, this patient, they're doing this, and they're not supposed to. Then I'd call down and say, hello, Deer Haven. So I had a spy there once in a while.
Oh,
not
that's great.
intentionally, but
Keeping tabs on making sure the patients are following orders. Well, any last thoughts today on your experiences in the medical care continuum for residents and long-term care?
I don't think I can think of anything.
Well, we certainly appreciate your time and your insight into how all of that care works in this community and the effects and impacts that has on our residents. And thanks so much for joining us today.
You're welcome.
you're welcome.
Thank you.